Thank you to the organizers for the opportunity to present as part of this conference. My talk today will focus on EEG monitoring in the pediatric intensive care unit. None of my disclosures relate directly to the items I'm going to discuss today. There are three key learning objectives. First, I'll discuss the incidence of electrographic seizures in critically ill children. Second, I'll analyze data regarding the impact of seizures on outcome. Third, I'll discuss current practice and guidelines related to EEG monitoring in critically ill children. Increasingly, we're using EEG monitoring in critically ill children for several reasons. The test is available at bedside and is non-invasive. It provides continuous information about brain function and provides diffuse coverage. Additionally, it's a functional test. For these reasons, EEG can provide objective evidence of brain dysfunction. It can allow us to identify general etiologies for encephalopathy. It can serve as a continuous function monitor to tell us whether brain function is improving or worsening over time. It can help us with prognostications for some etiologies, particularly hypoxic ischemic brain injury. But the most common reason we're using EEG monitoring in critically ill patients is to identify electrographic seizures and status epilepticus, and that's what I'll focus most of the talk on today. Among critically ill children with acute encephalopathy, electrographic seizures are relatively common. This is a summary of the literature to date. I've added the 95% confidence interval bars, and the fact that some of them are quite wide reflects small cohorts and likely explains some of the seizure incidence variability reported in the literature. Across all of the studies, though, about 5,000 patients have been reported, and the seizure incidence is 28%. That's remarkably similar across the larger studies of critically ill children, whether for heterogeneous etiologies, traumatic brain injury, brain infections, cardiac arrest, or patients undergoing ECMO. Electrographic status epilepticus is common in children experiencing electrographic seizures. Although it's been defined slightly differently in different studies, the key theme is that about a quarter to half of patients who are experiencing seizures are experiencing a substantial enough seizure exposure to be considered electrographic status epilepticus. Among patients who experience electrographic seizures, the majority of patients have exclusively or at least some non-convulsive, EEG-only, subclinical seizures. These would not be detectable by clinical observation alone and require EEG monitoring for identification. The minority of patients have exclusively clinical seizures, which would be detectable by clinical observation. Additionally, many patients who experience EEG-only seizures had not received paralytics. Therefore, we're not simply masking the convulsions through the use of paralytics, but there seems to be a true electromechanical uncoupling or dissociation where the patients can have these electrographic seizures without clinical manifestations. As we started initiating EEG monitoring in our pediatric intensive care unit, one of our first questions was how often the data impact clinical management. In a series of 100 consecutive patients, EEG data altered clinical management for 60%, pretty high for a non-invasive bedside test. The most common management change was anti-seizure medication changes, including initiation, escalation, or discontinuation. In about 20% of patients, anti-seizure medications were avoided because events that bedside clinicians really thought were seizures based on clinical observation were found to be non-ictal. Therefore, medications with potential side effects were avoided for those patients. As we started thinking about how to implement monitoring in our pediatric intensive care unit, we wanted to explore how different indications for EEG monitoring would impact the number of patients who underwent monitoring. Over 1 month, we screened every patient at bedside to see if they met different criteria. Overall, we screened about 250 patients, and depending on exactly how we set our indications, we would monitor between 10 and 80 children per month. In general, we've tended to monitor patients with altered mental status and an acute neurologic disorder in most of our clinical work and in some of the studies that I'll talk about going forward. Studies have identified a number of risk factors for electrographic seizures. Clinical risk factors include patients who are younger, especially younger than 1 or 2 years of age, patients with convulsive seizures or status epilepticus prior to EEG monitoring, patients with acute structural brain injury, including traumatic brain injury, and patients who have not received sedative medications. Several electrographic risk factors have been identified as well. The problem with some of these studies is deciding how to use these risk factors for an individual patient. What if a patient has one but not other risk factors? How do we decide which patients should actually undergo monitoring? We've tried to pull together some of these risk factors into seizure prediction models that could be used clinically. This was a study of about 700 consecutive critically ill patients, and we used multivariate logistic regression to build a seizure prediction model. In the final model, we included age, the acute encephalopathy category, whether there had been seizures prior to EEG monitoring, the EEG background category in the initial 30 minutes, and whether epileptiform discharges were present in the initial 30 minutes. Overall, the model performed well, although you can see on the right there is some overlap between patients predicted to have or not have seizures, indicating the model is not perfect. We subsequently validated the model in a separate cohort of about 300 patients. The generation and validation cohorts were generally similar, and the model performed generally in the same way across both cohorts. So how well would the model work? Suppose we were at a center with lots of EEG monitoring resources. We might decide to monitor anyone with a model cutoff score of greater than 0.1. If we implemented that cutoff, then we would save about 30% of our EEG monitoring, so a reduction in resource utilization, but we would miss about 8% of patients who experienced electrographic seizures. If we applied a higher cutoff of 0.15, we would further reduce resource utilization to about 43%, but we would miss about 11% of patients experiencing electrographic seizures. So the question becomes, is reducing EEG volume by about 30% worth missing about 10% of patients experiencing seizures? In our cohort, this would mean 14 patients didn't have seizures identified. At least in our group, we think this model is promising since it does provide an evidence-based way to decide on EEG monitoring utilization. However, we think that we need to try to do better, since although we want to use resources efficiently, this may be too large a proportion of patients to miss. Thinking about the duration of EEG monitoring may help us develop better models. This is a summary of the studies that have looked at electrographic seizure onset timing relative to EEG monitoring initiation. Overall, what you can see is that 1 hour of EEG would identify about 50% of patients experiencing seizures. For this reason, we tend to use very little routine EEG in our pediatric intensive care unit. If we see seizures, we would want longer monitoring to see if they stop. And if we don't see seizures, we would know that we were missing many patients with only a 1 hour EEG. 24 to 48 hours will identify about 80% of seizing patients, and so most patients undergo monitoring for that duration. Importantly, though, No study has ever recorded many patients for 5 or 10 days, and the studies are all based on clinically indicated monitoring. Therefore, we don't really know what the tail end is, and there may be a small proportion of patients who experience seizures after EEG monitoring that wouldn't be reported in these studies. Given those data, when surveyed, physicians report that they monitor most patients for about 24 hours, and then discontinue if seizures have not occurred. Physicians report monitoring longer, about 48 hours, if the patients have risk factors for seizures, such as periodic epileptiform discharges. We've tried to think in more detail about the impact of EEG monitoring duration, using some cost-effectiveness analyses to get at this issue. We performed a systematic literature review, generally including the data that we've reviewed up to this point regarding seizure incidence and timing, and then we figured out the costs to perform EEG monitoring in terms of physician and technologist time and equipment. We tried to use the true costs and not our charges or reimbursements. Then we determined how much would it cost to identify a seizing patient. The cost-effectiveness analyses indicated that if we were willing to pay $400 per seizing patient identified, we would do 1 hour of EEG. We would need to be willing to pay $1,600 per seizing patient to do 24 hours of EEG, and that amount is relatively common in the U.S. healthcare system. We would need to be willing to pay $24,000 per seizing patient to do 48 hours of EEG. So why the big jump in incremental cost-effectiveness ratio from 24 to 48 hours? Well, remember, we'll only identify a small proportion of extra patients seizing, but we'll need to monitor many patients for extra duration who will not seize. We used a similar approach to look at the cost-effectiveness of different durations of monitoring based on seizure risk. What you can see is that 1 hour or 24 hours of EEG has a pretty similar cost-effectiveness ratio, whether the patient has a high or low probability of seizures. However, 48 hours of EEG monitoring has a much higher cost-effectiveness ratio, and it becomes very high for patients with a low probability of seizures. Our summary of these data is that it may be reasonable to perform broad EEG monitoring in many patients for about 1 or 24 hours, but that we really need to think about which patients need longer duration EEG monitoring if we want to use this as a high value and appropriate strategy for widespread implementation. Recently, we looked at about 1,400 patients who underwent EEG monitoring in our PICU. Overall, the seizure incidence was 25%. We looked at the duration of EEG monitoring initiation to first seizure. In the overall cohort, what you can see is that we would identify about 50% of patients with just an hour of monitoring, 75% with 6 hours of monitoring, and then we would need 20 to 48 hours of monitoring to identify 90 to 98% of patients. The first lesson from these data is that half of seizures occur in the first hour, so close monitoring at EEG monitoring initiation makes sense. That first hour is going to be really important. Second, we broke the patients down based on whether or not they had EEG risk factors in the initial 6 hours, interictal epileptiform discharges, or periodic arrhythmic patterns that have been associated with seizures. You could see that among those who do have EEG risk factors, a smaller cohort of about 500 patients, the seizure incidence is 50%. Among those without EEG risk factors, a much larger cohort of about 900 patients, the seizure incidence is about 11%. So already we're seeing that we may be able to define cohorts based on whether or not there are EEG risk factors present. We then divided the groups in other ways, including by age, greater or less than 1 year of age, and whether or not there were clinically evident seizures prior to EEG monitoring. There are two main findings here. What you can see is that the two red arrows denote groups that you might initially say should undergo longer EEG monitoring. Those patients tended to have their seizures later, and you would need several days of EEG in order to identify 95 or 98% of patients experiencing seizures. However, also note, those groups with the red arrows are large groups with a very low seizure incidence. In contrast, the green arrows indicate cohorts of patients where the seizure incidence is much higher, the cohorts are smaller in size, and seizures tend to occur earlier during EEG monitoring. So we start seeing that we may have some higher value groups which have a high seizure incidence, the seizures occur early, and there are few patients. And those are the younger kids, those with prior seizures, and those with EEG risk factors. Similarly, we have lower value groups where there's a low seizure incidence, seizures may occur late, and there are many patients in those groups. Those tend to be older patients without prior seizures and without EEG risk factors. Taking into account clinical risk factors at baseline and emergent EEG risk factors that occurred during monitoring may help us define a targeted EEG duration for individual patients. Using multi-state survival modeling, we tried to determine how long we would need to monitor for the seizure risk to be less than 5% or less than 2%. We divided the cohorts into 4 risk groups based on age and whether or not clinically evident seizures had occurred. And then we determined whether emergent EEG risk factors occurred during the recording. In the multi-state survival modeling approach, patients entered at the entry state. They could then experience seizures. They could stay at the entry state. They could develop EEG risk factors but not experience seizures, or they could develop EEG risk factors and then experience seizures. Over time, patients would go through these loops. We could then plot out what is their risk over time of being in any one of these states, and we could plot out what is the remaining risk of experiencing seizures if they hadn't up to that point. We could do some math to calculate the transition probabilities and the seizure risk at different times, given those baseline clinical cohorts and emergent EEG risk factors. And that allowed us to determine how long we needed to monitor for the patients to be at less than 5% or less than 2% risk of experiencing seizures. Here's the overall summary. You can see that based on the patient age, whether they had clinically evident seizures prior to EEG monitoring initiation, and whether they developed EEG risk factors during EEG monitoring, that some patients would undergo about 6 hours of EEG, while other patients would undergo about 2.5 days of monitoring. So we could apply different durations of monitoring for different patients in a targeted approach. If we applied our model to the entire cohort, we would have performed about 21,000 hours of EEG monitoring. In contrast, if we had followed guidelines that recommended 24 hours of EEG for all patients, we would have had a 26% increase in monitoring utilization. If we had applied the 48-hour guidelines, then we would have a 37% decrease in monitoring utilization if we had applied our targeting model. So overall, we have similar resource utilization, including a slight increase or a more substantial decrease in monitoring compared to the 24 to 48-hour guidelines using this targeted approach. We could get the right patients the right duration of EEG monitoring. There's certainly more work to be done, but overall, I think what we're seeing is that we may be able to reduce EEG monitoring resource utilization without hurting care, which would allow electrographic seizure management approaches to be a high valuable and feasible strategy for implementation across many healthcare settings. We could use clinical variables in order to guide which patient should undergo screening EEG for 6 or 12 or 24 hours. Then we could use information from the screening EEG, like emergent EEG risk factors, in order to develop targeted approaches to EEG monitoring duration. And potentially we could also apply evidence-based approaches to review frequency, so high-risk patients got reviewed more, especially at the beginning, and lower-risk patients might get reviewed less frequently. We do all of this EEG monitoring to detect electrographic seizures so that we can treat them, since we hope that this reduces secondary brain injury and improves patient outcomes. What's the data underlying those issues? This is a tricky issue. We know that brain injury severity and extent influences outcome, and we know that brain injury can lead to acute symptomatic seizures. Those seizures can lead to systemic dysfunction, which can influence the underlying brain injury. If we treat those seizures with anti-seizure medications, those medications can lead to systemic problems, and if we use them long-term, they may influence long-term outcomes. So within this complex situation, we're trying to understand how acute seizures modify the relationship between brain injury and outcome. And of course, the answer is probably not the same for all patients, but will vary based on the patient age, the type of brain injury, the duration and extent of seizures, and how we assess patient outcomes. A number of studies have demonstrated that the presence of seizures is associated with unfavorable outcomes in these patients. But a number of the early studies had one key problem. It was unclear whether the seizures actually led to worse outcomes, or whether the seizures were simply a biomarker of worse brain injury. The patients might have had worse injury, and so they seized, and they had worse outcomes. Recently, though, a number of studies have used multivariate analyses to try to adjust for different variables reflecting the type and severity of brain injury, and then assessed the impact of seizures on outcome. Among the studies that have used these multivariable approaches, the key theme has been that brief or low seizure burdens may not impact outcome, while higher seizure burdens have been associated with worse outcomes using a variety of outcome measures and a variety of multivariate models. In one of our early studies, we looked at 200 consecutive patients who underwent monitoring, and they were categorized as having no seizures, electrographic seizures, or electrographic status epilepticus. We used an adjusted analysis, and we found that patients with electrographic seizures did not have worse outcomes, while patients with electrographic status epilepticus had higher mortality and a higher odds ratio for worsening in their PCPC scores at discharge. This made sense to us that perhaps brief seizures don't lead to secondary brain injury and worse outcomes, at least in a way we could measure, but that high seizure exposure might lead to secondary brain injury and worse patient outcomes. The Toronto group has done a similar analysis, except instead of categorizing seizure burden, they looked at the percent of the worst hour that contained seizures. So a 50% seizure burden meant 30 out of 60 minutes was spent seizing. They did a multivariate analysis, and they found that once patients had a 20% seizure burden, or 12 minutes per hour, that was associated with an increased probability and magnitude of neurologic decline across all of their diagnostic categories. We recently looked at outcome in a much larger cohort of about 700 patients with acute encephalopathy who underwent EEG monitoring. We performed a multivariate analysis and had similar findings. Seizures were not associated with worse outcome, but electrographic status epilepticus was associated with unfavorable Glasgow outcome score for PEDS and unfavorable PCPC scores. We've looked at longer-term outcomes as well. In one study of patients who were normal prior to ICU admission, outcome was assessed at a median of 2.6 years. We used a multivariate analysis approach and found that seizures were not associated with worse outcome, but electrographic status epilepticus was associated with worse outcomes in terms of Glasgow Outcome Score for PEDS, Pediatric Quality of Life scores, and a much higher risk of experiencing subsequent epilepsy in patients who did not have epilepsy prior to admission. There are several implications to these studies. Overall, they've identified association between high seizure exposure and worse outcomes. Maybe that means that we should manage and aim to stop electrographic status epilepticus from occurring, but that we could tolerate some brief electrographic seizures. Certainly we don't know what the exact cutoff is between seizures and status epilepticus, and it probably differs in different patients and acute neurologic disorders and seizure characteristics. And some patients with untreated seizures might progress towards electrographic status epilepticus and need treatment. However, I think the fact that the data indicate that missing a couple brief seizures may not be a huge problem allows us to think about this in a much more realistic approach for widespread implementation. Missing several very brief seizures might be okay if we have a strategy that keeps patients from experiencing a substantial seizure exposure. In terms of treatment, a survey of physicians indicated that most would treat if any non-convulsive seizures would occur, although some would only treat if there had been multiple seizures. In terms of the treatment goal, most physicians aim to terminate all seizures, although some would tolerate 5 or 10 seizures per day, figuring it wasn't worth escalating treatment if the seizure burden was low. Physicians reported that for both non-convulsive seizures and non-convulsive status epilepticus, they would treat with the drugs generally used for convulsive status epilepticus, including lorazepam, phenytoin or fosphenytoin, or levetiracetam. We looked at seizure treatment at our center in patients in the PICU with electrographic seizures, and this was done before we had any sort of pathway guiding management of these patients. Among 84 patients with electrographic seizures, 81 received medications, and they were about equally spread between phenytoin, phenobarbital, and levetiracetam. It's hard to really talk about efficacy for an observational trial since there was no comparison group, and the seizures might have ceased on their own. However, we defined efficacy as seizures stopping after the first anti-seizure medication was administered, so the patient didn't need additional medications. What you can see is that the medications phenytoin, phenobarbital, and levetiracetam all had similar efficacy when defined in that way. Additionally, what you can see is that they seem to have higher efficacy when they were administered because of ongoing electrographic seizures, working in about 60%, and a lower efficacy of about 20% when electrographic status epilepticus was already ongoing at the time of treatment. That finding was consistent with studies from convulsive status epilepticus, in which medications seem to be more effective if they're administered early during the status epilepticus than when the same medications are administered at the same doses later in status epilepticus. So maybe if we could treat these patients more quickly when they were just experiencing seizures, the medications would have higher efficacy. Given that most physicians aim to treat electrographic seizures when they occur, we had always been concerned about whether treatment led to more adverse effects than we were recognizing. In a study of about 500 critically ill patients, 131 experienced seizures and 108 were treated with anti-seizure medications. 44% received only one medication, 22% received 2 meds, 20% received 3 meds, and 14 received 4 or more medications. Seizures terminated after the first or second drug in about 70% of patients, while some patients required more medications and about a quarter of patients required pharmacologic therapy. So many patients could be treated with one or two standard anti-seizure medications. We assessed for adverse effects in detail using a detailed grading system, and we found that 17% of patients did have adverse effects. These were mostly considered serious, severe, and related to the anti-seizure drugs. However, all of them were readily managed by intensivists and resolved. Further, we found that these adverse effects were very rare with patients who had experienced electrographic seizures and were treated with one or two seizure medications. They were much more common in the patients with pre-existing epilepsy, with more complex EEG patterns and more extensive anti-seizure medication management. For example, adverse effects occurred in only 9% who were treated with seizures, but 42% who were treated with status epilepticus. Similarly, adverse effects occurred in only 5% of patients who did not need more than two medications, but 40% of patients in which seizures persisted after a second anti-seizure medication. So adverse effects did occur, but they were treatable and manageable, and they were very rare in the patients with electrographic seizures that resolved after one or two medications. We've also looked at the impact of seizure treatment timing. Before we had a pathway, we looked at how long it took for us to initiate treatment after electrographic seizures occurred on EEG monitoring, and we found that it took about 139 minutes. We didn't intend to be slow, but by the time we saw the seizures, called the neurology consult team, who would call the PICU team, who would order an anti-seizure medication, which would eventually come up from pharmacy and be administered by the nurse, a bunch of time went by. We then initiated a pathway in which we aimed to streamline this approach. We reduced the number of staff that were involved in this communication line. We put the right medications in our Pyxis machines in the pediatric intensive care unit so that anti-seizure medications could be obtained more quickly. And we developed an interdisciplinary pathway and then educated people on the pathway. After the pathway, our time to treat decreased to 64 minutes. Now, I certainly wish we were even quicker than that, but that was a substantial reduction without any major technological advances. We just improved communication and medication placement. Interestingly, while the study wasn't designed to look at efficacy of treatment, we found that seizures terminated after the first drug in only 26% of patients before our pathway when we were slow to treat, but in 67% of patients after the pathway was implemented, when we were quicker at treating. That finding was similar to data available for convulsive status epilepticus, in which quicker treatment with the same medication at the same dose is more effective than later treatment with that same medication. So maybe by treating these patients more efficiently and more quickly, they were more likely to respond to treatment, and therefore they wouldn't need to escalate to treatment with multiple anti-seizure medications, which would be associated with a greater risk for potential adverse effects. Pulling together those studies, I think there are several conclusions. Rapid treatment is associated with higher initial anti-seizure medication efficacy, potentially reducing the occurrence of electrographic status epilepticus and the need for multiple anti-seizure medications. Additionally, treating seizures with one or two anti-seizure medications is associated with a very low risk of adverse effects. Therefore, approaches in which we act quickly, potentially using preliminary data from technologists screening the EEG or quantitative EEG, might be useful even if there was some unnecessary anti-seizure medication administration. Giving the medication early may be more beneficial, and maybe over-treating a small number of patients that eventually we determined did not actually have seizures could be appropriate. The key would be not escalating to numerous anti-seizure medications, which have a greater risk for adverse effects, unless we were very sure, based on conventional EEG review by electroencephalographers, that there truly was a high electrographic seizure exposure worth escalating treatment. As we perform an increasing amount of EEG monitoring in critically ill children, as well as seizures, we're often identifying periodic and rhythmic patterns. The American Clinical Neurophysiology has developed standardized terminology for ICU EEG, including these patterns, and adult studies have evaluated these patterns in critically ill patients. There have been relatively fewer studies in children. We recently looked at these patterns in about 14 critically ill children, with these patterns evaluated by 2 electroencephalographers. Inter-rater agreement for the key terminology was nearly perfect or substantial. Periodic and rhythmic patterns occurred in 10% of patients, including ictal-interictal continuum patterns in 7%. The most common patterns were GPDs, LPDs, GRDA, BIPDs, and LRDA. Several of these patterns were associated with electrographic seizures, including GPDs, LPDs, BIPDs, and LRDA. GRDA was not associated with seizures. Those are the same associations that have been demonstrated in critically ill adults. Additionally, in about half of patients, seizures and periodic and rhythmic patterns occurred within 6 hours of each other. This indicates that these patterns may occur along a spectrum and suggests that patients with these patterns should be evaluated carefully, since seizures are likely to occur when the patterns are occurring. For EEG monitoring to be a valuable neuroprotective strategy, it has to result in management that improves outcomes, and that's much of what we've discussed up to this point in terms of identification and management strategies. However, the second important point is that widespread implementation has to be possible. Part of widespread implementation may involve quantitative EEG approaches. Quantitative EEG has several main purposes. First, it allows data reduction. Electroencephalographers reviewing one page of conventional EEG at a time have a huge number of pages to review, which can take several hours. These quantitative EEG approaches can focus review on the segments containing potentially important changes or events. Second, quantitative EEG may simplify EEG in such a way that we can engage bedside caregivers and thereby expand our EEG workforce. They're often used to following monitors at bedside and are often available 24/7 in the intensive care unit, which can lead to more frequent interpretation. This could yield true monitoring as opposed to continuous data acquisition with intermittent review, which is the current practice at many institutions. Finally, quantitative EEG trends may allow us to visualize changes that occur slowly over time, which may be difficult to identify when looking at brief segments of conventional EEG. Here are demonstrations. On the top is 7 seconds of conventional EEG. We would review many screens, put in notations, count up the notations for seizures, and count seizures in that manner. On the bottom is 3 hours of EEG, and what you can see is that each of the changes on the quantitative EEG trends represent electrographic seizures. Once we know each of those changes is an electrographic seizure, through a view of the conventional EEG associated with that point in time, we can quickly determine that the patient is still experiencing seizures and escalate treatment without necessarily needing to look at every segment of EEG in that time period. Here's an example of what these trends may look like. On the top is conventional EEG. The next rows in black and white show amplitude integrated EEG for the 2 hemispheres, and the colored rows show density spectral array EEG for the 2 hemispheres. When seizures occur, there's an increase in amplitude and an increase in power, leading to the arches on amplitude integrated EEG and the red flames on density spectral array EEG. As indicated by the red arrow, each of those is a seizure, so we can easily see that this patient is having seizures and determine whether more treatment is needed. Here's another example, and this is like what I find we often see in clinical practice. Your eye may be drawn to that arrow with the black line, looking like an arch or a flame. However, when you look at the conventional EEG, it confirms that all of that is artifact. If you look at this smaller arch and flame, in fact, each of those is an electrographic seizure. So what you see here is that potentially these quantitative EEG trends can lead to false positives, in which case we might think the patient is seizing and escalate treatment that isn't needed, or false negatives, in which we miss seizures. So how well do these trends work? We've done a number of studies with slightly different methodologies in which we show groups images like those shown on the bottom. We've done this with different types of trends, different hemispheric distributions, and different learners, including neurophysiologists, intensivists, and nurses. And overall, the data are remarkably similar with the different approaches and different users. Sensitivity is about 0.7, indicating we may miss seizures with these techniques. Specificity is about 0.7, indicating that we may identify artifact as seizures. It's good news that users with very basic training over a short period of time can use these techniques as well as neurophysiologists who have more EEG experience. However, these numbers also suggest there are some limitations to these techniques, where they may work well in some patients with some types of seizures, but not well in other patients. The Toronto group has also looked at these types of trends. They've looked at density spectral array and amplitude integrated EEG when reviewed by ICU fellows, nurses, neurophysiologists, and EEG technologists. Again, there were generally similar data across those different user groups. Sensitivity was about 70%, positive predictive value was about 95%, and the false positive rate was about 0 to 5 per day. Thus, again, these techniques may miss seizures and they may identify artifact as seizure. Several studies have identified factors which we may be able to modify in order to make these trends work better. Display size, interpreter experience, and trend combinations all make a difference. However, there are some factors which are just not modifiable. For example, focal seizures which don't occur in the region being assessed with a quantitative EEG trend may not be identified. Additionally, short seizures may not be identified, since when time is compressed, it takes a longer seizure to occur for a long enough period of time to generate one of those nice arches or red flames seen on the prior examples. Despite these limitations, quantitative EEG trends may be useful by intensivists. In a recent study at a single center, intensivists used quantitative EEG at bedside. Neurophysiologists were not available nights or weekends, but conventional EEG was recorded so that it could be reviewed later once the neurophysiologists were available. The intensivists checked the quantitative EEG trends relatively frequently and were educated using lectures and written material. When neurophysiologists reviewed the conventional EEG as the gold standard, electrographic seizures occurred in 12% of the patients. They didn't identify any patients with seizures who hadn't been identified by intensivists using quantitative EEG. Additionally, the seizures occurred outside of the neurophysiologist's working hours for 67% of those patients, meaning those patients wouldn't have had their seizures identified if the intensivists hadn't been using quantitative EEG. The PICU clinicians identified seizures in 23 of 101 patients. That included 12 true positives and 11 false positives, so there were false positives. The positive predictive value was 52%, and the negative predictive value was 100%. All of the true positive, truly seizing patients, and false positive patients, those who weren't really seizing, received anti-seizure medications, and there were no adverse effects. So quantitative EEG use did lead to some overtreatment, but there were no adverse effects, and it led to identification of seizures that wouldn't have been identified since the neurophysiologists were not available at that time. So is quantitative EEG good? Often this devolves into neurologists saying it's imperfect, so we should stick with conventional EEG, and neonatologists or intensivists saying that it's something that they can use when neurologists are not available. I would propose that the better question is how can we best use quantitative EEG as a hybrid strategy along with conventional EEG? That may offer the best value. If we don't have neurology confirmation, quantitative EEG needs to have high sensitivity so we don't miss seizures, and high specificity so we don't overtreat artifact. That's tough for any test, to have really good sensitivity and really good specificity. However, if we have neurology available to look at conventional EEG when needed, then we may need quantitative EEG to have high sensitivity so we don't miss seizures, but we could tolerate a much lower specificity because a neurologist can confirm using conventional EEG that the events are seizures as opposed to artifact before treatment is initiated. In this way, this hybrid approach may allow us to use quantitative EEG to identify patients who are definitely not seizing, and therefore allow us to focus our conventional EEG review on patients who may be seizing. A number of guidelines and consensus statements have been published related to EEG monitoring in critically ill children and neonates. The initial statement was from the American Society of Electroneurodiagnostic Technologists. This was before most of the physician-related statements. I think this is a useful document since it points out that EEG technologists can do much more than apply and disconnect electrodes and run the EEG machines. It points out that technologists can be a critical component of the care team, providing education about EEG to patients and families and physicians and nurses at bedside, helping to collect history, medication information, and ICU data, running the EEG, communicating with ICU staff about events and plans, and helping to screen the EEG. Using EEG technologists as a key part of the care team allows us to provide for expanded services to a larger number of patients. The American Clinical Neurophysiology Society has a consensus statement on continuous EEG in critically ill adults and children. There are several indications, including diagnosing non-convulsive seizures in patients with altered mental status after convulsive seizures, acute supratentorial brain injury with many etiologies, fluctuating or unexplained mental status changes, or paroxysmal events suspected to be seizures. We can use it to assess therapy for seizures or status epilepticus. We may be able to use it to identify cerebral ischemia. We can use it to monitor sedation and high-dose suppressive therapy. And in some etiologies, we can assess the severity of encephalopathy and provide prognostic information. The consensus statement from the American Clinical Neurophysiology Society also provides useful recommendations about procedural issues. It recommends that we have written pathways developed in advance in order to guide use of EEG monitoring, that it be supervised by physicians with training and experience in critical care EEG, that we should try to have it available 24/7, and that the usual monitoring duration is 24 to 48 hours. Additionally, they indicate that we should review it at least twice per day, but often more often, in order to provide monitoring and not just intermittent review. The Neurocritical Care Society also has a guideline for the evaluation and management of status epilepticus. While most of the guideline relates to convulsive status management, there are several points related to EEG monitoring in critically ill patients. First, the definition of status epilepticus is 5 minutes or more of continuous clinical or electrographic seizure activity. So they've lumped together convulsive status and electrographic status as both being related to the treatment recommendations in this guideline. They suggest that we should treat status epilepticus until all electrographic seizures are halted. Well, we need EEG monitoring in order to determine whether those electrographic seizures are happening or not. And they recommend that we should perform 48 hours of monitoring in comatose patients in order to evaluate for non-convulsive seizures and status epilepticus so that we can treat it if identified. They provide indications for EEG monitoring, which are very broad. Patients with clinical seizures or status who don't return to baseline in 10 minutes, patients who are comatose, patients with various types of intracranial hemorrhage, patients with suspected non-convulsive seizures and altered mental status, or patients with EEG risk factors on a brief EEG. They are clearly recommending casting a very wide net in terms of indications. Given these data and the related guidelines and consensus statements, there is increasing use of EEG monitoring. In one study, centers in the United States and Canada described a 30% increase in the number of patients undergoing EEG monitoring over just 1 year. Additionally, EEG monitoring was being used in patients with altered mental status from a variety of etiologies, but was also embedded in the care pathways for a number of conditions such as cardiac arrest, traumatic brain injury, or patients undergoing ECMO. A number of other surveys of neurocritical care consultation services or members of the CNS regarding status epilepticus management have suggested that continuous EEG monitoring is being used widely by neurocritical care consultation services, that most physicians have access to EEG monitoring, and that it's often used after status epilepticus. A study using the Kids Inpatient Database with data from 2010 to 2012 indicated that a small number of patients who probably meet indications for EEG monitoring actually underwent monitoring. Among patients who are critically ill, mechanically ventilated, and with indications such as TBI or HIE, only about 5% underwent video EEG, 3% underwent routine EEG, and about 5 to 10% underwent any type of EEG. These numbers may have increased if we looked again today. A quality improvement study recently suggested that a brief intervention could help identify and ensure that patients who should undergo EEG monitoring do undergo EEG monitoring. In this quality improvement study, about 20% of patients in the PICU met criteria for EEG monitoring, and 98% met those criteria on admission. Prior to their intervention, only about 23% of patients who met ACNS indications actually underwent monitoring. They performed an intervention consisting of a simple 15-minute didactic lecture and summary handouts listing the indications for EEG monitoring. Following the intervention, 83% of patients who met indications underwent monitoring. Therefore, this suggests a relatively simple intervention could lead our intensivists to identify more patients who should undergo monitoring based on these guidelines. At our center, we have an ICU EEG monitoring pathway, and all of our pathways are available online on the internet. The pathway aims to address many of the issues in the related guidelines and consensus statements, but to bring those guidelines and consensus statements into our practice situation based on how we need to do things given our institutional peculiarities. We list our EEG monitoring indications, the workflow in terms of hooking up patients and different communication issues, what we do if seizures occur, and then how we discontinue monitoring. The pathway is developed in an interdisciplinary manner with neurology, neurophysiology, critical care medicine, neonatology, pharmacy, information technology, and quality and safety representatives. We update it at about yearly, and importantly, it's advisory but not mandatory. We hope that it guides the care for the majority of patients, and therefore it allows our clinicians to use their time in order to address the smaller proportion of patients that don't exactly fit on the pathway. This degree of standardization has also enabled us to perform clinical research and quality improvement work based on our large clinical operation. Increasingly, we've included EEG monitoring in a decision support mechanism. Many of our order sets, such as cardiac arrest, TBI, ECMO, neonatal HIE, congenital heart disease, and several exploratory order sets, contain EEG monitoring in order to help people remember that monitoring is indicated for those patients. Additionally, when monitoring is ordered, the order set also places various nursing instructions regarding push-button events and logging of medication administration. Additionally, the order set provides guidance to the clinicians on which anti-seizure medications they can order in advance, so that the medication has already been considered and ordered and can be given quickly if seizures occur on EEG monitoring. We've looked also at decision support in terms of reporting. Based on the ACNS critical care terminology, we've developed smart forms, which are data elements in our medical record that we use for clinical reporting. This allows us to efficiently generate reports using a format that our consultants and intensivists learn to understand and rely on. It also allows us to provide embedded information about definitions for some of the terms in order to help standardize reading across electroencephalographers. We've assessed the acceptability of this standardized EEG reporting system, and most people found that they would recommend it and that it helped their workflow efficiency. Additionally, this allows us to use our vast clinical operation and reporting system in order to help gather data for clinical research and quality improvement projects. Overall, what we're seeing is that EEG monitoring in critically ill children may be a high-value and feasible neuroprotective strategy. We can use prediction rules in order to optimize utilization of resource-intense EEG monitoring. I think that in the future, strategies may use broad but short duration monitoring for 12 to 24 hours, with much more targeted use of longer monitoring in patients specifically considered at risk for seizures to occur later. Since low seizure burden is not associated with unfavorable outcome, we might be able to tolerate some brief electrographic seizures, and failing to detect every brief seizure might not be a failure of our systems. Our goal may be to avoid development of electrographic status and to treat patients with a high seizure burden. This may be a much more reasonable approach for widespread implementation. There's increasing data that we can treat many patients with electrographic seizures using just one or two standard anti-seizure medications with a very low adverse event risk. Treating quickly may avoid the need for multiple seizure medicines, may avoid development of electrographic status epilepticus, which is associated with worse outcomes, and may reduce the need to escalate to multiple seizure medications, which are associated with an increased risk for adverse effects. Quantitative EEG may improve seizure identification, timing, and efficiency. Some false negatives in which we miss brief seizures, and some false positives where we overtreat with one or two anti-seizure medications may be reasonable strategies. Development of hybrid approaches in which you use quantitative EEG screening and conventional EEG confirmation may be ideal. Finally, Clinical pathways may enable mass customization and allow us to link clinical operations, quality improvement, and clinical research. Thank you again to the organizers for the opportunity to participate in this conference. Thank you also to funding organizations including NIH, CHOP Pediatrics, and the Wolfson Foundation, and especially to our ICU EEG team, which have developed many of the data I presented today, particularly including Alexis Topjan in the Pediatric Intensive Care Unit, and my fellow ICU EEG readers, Franz Fung, Siobhan Massey, and Mark Fitzgerald.